How's it going, guys? We have a medium difficulty question for pathology, step 1, internal medicine, 2CK, 40-year-old woman, 12-month history of fatigue, weight gain, irregular menses. Vitals are temperature 98.6, heart rate 55, respiratory rate 12, blood pressure 120/80, BMI 25. During the interview, she responds with short, quiet remarks and minimal eye contact, which the following additional findings is most likely to be seen in this patient. Let's hop through the answer. Choice A, apple, green, birefringence, congruent stain. Wrong fucking answer. This will trigger some students here because you can technically go on Google, find like 50 different causes of amyloidosis, okay? That's what this refers to. So amyloid, beta, pleated sheets, apple green birefringence congruent stain, classically medullary thyroid carcinoma. That's the highest yield reference to this on USMLE. Obviously, it could be renal amyloidosis, cardiac amyloidosis. More obscure causes, such as autoimmune disease, it's not impossible. Okay, it's not impossible. As I said, some of you are getting emotional right now. But it's not the most likely answer. Wrong fucking answer. Choice B, decreased serum cholesterol. Wrong fucking answer. So we would have increased serum cholesterol in this case. You say, well, how do we know what's actually going on here? All right, well, diagnosis is Hashimoto thyroiditis. So you don't have to have a high BMI. 25 is upper limit of normal. Well, she's got fatigue, weight gain, irregular menses, menstrual irregularities, exceedingly high yield for USMLE for hypothyroidism. The mechanism's a little bit unusual. I mean, if we have decreased thyroid hormone, that can lead to increased TRH, which can stimulate prolactin release. I don't like that mechanism because it can get you questions wrong otherwise. You need to know that the main mechanism for prolactin regulation is dopamine. Okay, so dopamine inhibits the release of prolactin, and that's important because questions are 99% more likely to mention a severance of the pituitary stalk, where because we no longer have dopamine mediated inhibition, prolactin can go up. Some students ask about the TRH effects. It's nonsense, but I'm just letting you know why that there can be menstrual irregularities with hypothyroidism. I gave you bradycardia here. This is a sneaky thing USMLE will do. They'll give you a heart rate of 55 to 60. If you have a heart rate of 72, don't exclude hypothyroidism. I'm just telling you that it's a convenient, if you're starting to think, ooh, maybe this is hypothyroidism, then you look at the heart rate and you see it's 55 or 60, boom, okay? It's what USMLE likes to do as per my observation. And then, of course, healthy people can have that, but I'm just pointing it out. And then she's got what appears to be dysthymic mood here. She's got low mood. We don't know necessarily if it's depression or not, but you need to know that hypothyroidism is a cause of dysthymia/depression, okay? So they can give you increased serum cholesterol in hypothyroidism. I've seen vignettes with that, okay, especially in TCK level stuff. They'll say total cholesterol 300, so you just need to know dyslipidemia can be seen with hypothyroidism. Choice B, wrong fucking answer. Choice C, decreased serum creatine kinase. Wrong fucking answer. If you're wondering how this relates, well, if anything, you could have increased serum CK in thyroid derangement because of hypothyroid myopathy. Okay, obviously thyroid storm. Okay, there are instances where hyper as well can cause CK to go up, but proximal muscle weakness/pain, and you can get liberation, breakdown of some of the skeletal muscle, and you can get increased serum creatine kinase. You'll see that as well sometimes in NBMEs. Wrong fucking answer. Choice D, decreased serum transaminase is wrong fucking answer. So some confusing answer choices here, right? Well, I've harped on in some of my prior YouTube clips. I also mention it in my PDFs that USMLE can give you elevated ALT and or AST in hypothyroidism. Think it's weird? Don't take it up with me, take up the NBME exams. You'll get a vignette of hypothyroidism. They'll say serum AST is elevated. They don't say anything about ALT. And you're like, what the hell? You're like, why is AST elevated? As I just said, sometimes you can get transaminitis with thyroid derangement. In this case, wrong fucking answer. Choice C, lymphocytic infiltration, correct answer. So you need to know Hashimoto thyroiditis, aka chronic lymphocytic thyroiditis. That's the other name for it. And they want you to know, they'll ask straight up, you just have a lymphocytic infiltration within the thyroid gland. Okay, it's a biopsy finding. I've seen them ask this on USMLE. So short point of consolidation here is that you need to be able to expand your awareness for findings in hypothyroidism beyond just cold intolerance, constipation, weight gain, okay, brittle hair, dry or doughy skin. USMLE often omit those findings because they're too easy. So menstrual irregularities, high yield, increased serum CK, hypothyroid myopathy. You can get hypercholesterolemia, you get transaminitis, dysthymia / depression, bradycardia. You know the deal. Until you make more content, if you like my stuff, subscribe my channel. And I appreciate your time. That's it.